In our TechNation Wednesday webinar series. We are thrilled to have over 175 pre-registered attendees for today's presentation. We are proud to offer these free webinars as a way to educate and provide valuable information to the healthcare technology industry. Looking ahead, our next webinar Wednesday will be May 28th, featuring Manny Roman, discussing the 7 triggers to yes. In June, due to overwhelming demand, we will have 3 webinar Wednesdays on the 11th, 18th, and 25th. We would like to mention that many of these same speakers and presentations are held at our tri-annual MD Expos. Our next MD Expo will be the inaugural MD Imaging Expo in Indianapolis, July 16th and 17th. Please visit mdexposhow.com for more information. As always, admission is free to hospital employees, military, and students at all MD Expos. Okay, a few notes before we begin. Your participation today makes you eligible for 1.5 CE credits. A survey about today's presentation will appear on your screen immediately following today's webinar. Once the survey is complete, we will email you your certificate with the CE credits within 2 weeks. In today's webinar, all lines will be muted, but you can submit questions during the presentation by using the questions feature on the dashboard on the right-hand side of the screen. Also, you will be asked to use the raise your hand feature throughout today's webinar. You will also find this feature on the dashboard. Our presenter was kind enough to provide a PDF of HTM benchmarking data for our registered attendees today. You should have received a copy via email. However, you can download the information now by visiting www.imtechnation.com/webinars. We will send a summary of today's webinar to all attendees after today's webinar. If you have any difficulty whatsoever during today's webinar, please email us at webinar@mdpublishing.com. Before I introduce today's presenter, we would like to thank today's sponsor, Heritage Global Partners, a leading full-service global auction and asset advisory firm. Please visit www.hgpauction.com to learn more about a special 2-day global online auction, May 27th and 28th, featuring RCOA's mobile fleet of PET and CT imaging systems. Okay, before I introduce our presenter, I'd like to do a little get fired up ceremony here. So when I say I am, I want everybody out there to yell TechNation. I am TechNation. I am TechNation. Okay, now we're ready. Last but not least, I want to introduce to you a very special presenter, Karen Waniger of Community Health Network. She has over 20 years in the field of healthcare technology management, 10 years of hands-on experience as a service technician, 10 years in leadership roles as service manager, regulatory compliance director, and service director. Thank you so much, Karen. Take it away.
Thanks, John. Good afternoon. I can't talk today. This isn't going to be good. Good afternoon, everyone, or good morning if you're joining from the West Coast. I sound like I just woke up, but that's not true. I've actually been here a while today. As John said, I'm Karen Waniger. My current paid role is Director of Clinical Engineering for Community Health Network in Indianapolis. I love being part of this profession. I am a member of the Indiana Biomedical Society and the AAMI Technology Management Council. I also have the pleasure of being a contributing writer for TechNation magazine. And I'll be using the next hour or so to share some of the reasons to use benchmarking and hopefully help you have a better understanding of the way it's supposed to work. I've been in the world of HTM for 20+ years, as John said, and I've been using some form of benchmarking for most of that time. Thanks again to our sponsor and to you all for joining TechNation. So let's get started. Our organization is doing this whole initiative around making sure that we introduce ourselves to our patients. And that applies on the service side as well, introducing ourselves to our customers to make sure they know who we're doing and what we're doing. And so that was what I just went through, was an acknowledgement, an introduction, the duration of how long we're going to be here, a little bit about my experience, and a thanks. What does this have to do with benchmarking? Nothing, really. But what it does is set the stage for how we should treat our customers and how we should interact with one another. And I believe we all benefit from sharing experiences, ideas, solutions. So please feel free to ask questions during my presentation at any point. Our facilitator will pass them on to me. Thank you. So what are we going to do today? In the time that's available, I hope to help you understand more about what benchmarking is and share some tips about how to make the process work. It seems to help people understand why when we ask them to do something. So I'll give you some of the external reasons we should be tracking our performance and share some examples of how the data has been valuable internally as well. I like this definition of benchmarking, and to get everybody on the same page with the same perspective for today, this is the one we're going to use. It's from a textbook, Robbins and Coulter, the 2007 edition, and they define benchmarking as the search for best practices among competitors or non-competitors that can lead to their superior performance. So how do we do that? We can learn from our competitors as well as from within our own organization or even from other industries if we start by looking around. We have to look to see what's happening around us. I like the beach, so there's an analogy that I like to use. If we never look around at the beach and we're playing in the waves, we won't know how hard to brace ourselves for the next wave that's coming. We won't know what direction it's coming from or where it's going to hit us. In healthcare, we know there are going to be waves of change coming at us. We just never know how hard they're going to hit or when the next one's really going to get here. So with benchmarking, when we look around, we want to look for anything that seems to be better than average or worse than average so that we can find out how to replicate the things that work well and how to avoid the things that don't work well. And so in doing that, it's helpful to identify targets that seem to be similar to the ones that we use, organizations that are similar in mission, size, scope of service. There are some formal processes out there. This is the audience interaction part. If you would click on that raise your hand button, if any of you are currently using a formal benchmarking program like AAMI, ECRI, Action OI, or some other formal program, I just like to get a feel of how many people from the audience are really already involved and engaged in doing benchmarking. And while that data is coming in, I'll share a little bit of a benchmarking success story. We had the opportunity to bring on a cath lab service specialist because we had been collecting data about the money we were spending on contracts, the number of service calls, and some anecdotal information about, dissatisfied customers. So, Jamie, do you have results yet? I'm not seeing it pop up. Okay, thank you. So we've got a few coming in. We'll give people a little bit more time to respond, and I will go on to the next slide, and I'll keep watching for responses. So the process of benchmarking, and this is a formal process. It's a gradual path to take you from where you are today to the level that you want to be at, but it is a formal process. You start down in that bottom left of the slide, identifying what to benchmark, who to compare, and the data collection method. Once you have that established, you move on to that next step in the process, which is to form the team. And that's a planning team as well as an implementation team if you need it. And then you start to gather internal and external data. Once you have that team with their data gathered, collectively you analyze the data. And the importance of the team here is because everybody has a different perspective and a different level of experience that they can bring to the conversations as they are analyzing the data, preparing the action plan, and then definitely as you're implementing it, you need buy-in from everyone on that team. And once you have that plan and you implement it, ideally you achieve that best practice performance level. And even if you don't achieve that level immediately, you have hopefully made some progress in moving up that curve towards improvement. All right, it looks like the answer is that we have 11 people who are currently using a formal benchmarking process. And I understand that there are some difficulties around that. And I won't even get into that. My purpose for today is to share with you that benchmarking can be done with or without a formal process. So hopefully you find this of value as we go on through here. And again, thank you for any comments or any questions as we go through, and Jamie will pass those on. Our success story, putting our efforts onto that graph just to help you visualize how it all worked in our process of improving and getting that imaging specialist position created. We identified what to benchmark. We looked at our service contract costs, the number of equipment failures. Those were our two primary things that we were measuring. And we compared that to what we believed we could do as an in-house organization. And again, realizing that we had no data to base that on other than similar experiences. Our team included the cardiac cath lab managers, key physicians, as well as our own technology management service team. The data analysis indicated an opportunity to reduce our costs by $250,000, and that wasn't a one-time cost. That was annually, and that was beyond the cost of hiring the position, filling the position, paying for the benefits, buying the tools, test equipment, everything else that we might need. But we were able to use that data to build the business plan to support the position request, and we were able to hire that service specialist. And what that resulted in, thankfully, was customers that are satisfied, costs that are lower for the organization, and a lower failure rate on those pieces of equipment. And we also continued to track our performance after that position had been approved, just to verify that we did make a good decision. As you can see from this slide, we filled the position in 2011. So in 2010, which was the first year that we actually started tracking the cath lab service, we had an average repair per device, and we had 5 of these labs. Average number of repairs per device was 15.2, total of 76 service calls that year. And that wasn't counting PMs. That was just the service calls on those 5 cath labs. In 2011, after we had brought that in-house, that number decreased to 30. And then 2012, it went back up a little bit to 55, but back down again in 2013. So the importance of this data actually ended up helping us in another scenario as we were working to contradict, or at least to try to justify to CMS why imaging equipment should be able to be supported using an alternative equipment method. This information was useful. We didn't win, but it was still useful. So if you want to know more about the CMS requirements for imaging equipment, that's a whole separate presentation, but it will be happening at the MD Imaging Expo here in Indianapolis in July, as Don mentioned. So now back to benchmarking.
Karen, excuse me. I'm sorry,
yes.
Karen. We had a question come through, if I could interrupt you and have this answered. From James, the question is, did you benchmark against a gold 24/7 contract price?
It was a gold 24/7 contract price. That is correct. And then we also benchmarked it against just the standard extended hours, the 8 a.m. to, I think theirs was 9 p.m. We benchmarked it against both of those, but that $250,000 savings was against the gold. Does that answer the question? Hopefully it does. We'll move on. I hate webinars that I can't get instant feedback from my attendees. Thank you all for going along with this. All right, so now back to benchmarking. Why do we need to track our performance? So there are a few external factors I want to talk about here. Hopefully by now most of you have heard about HCAHPS. What about value, or VBP? Sorry, I almost gave you the answer. See, VBP. HCAHPS is Hospital Consumer Assessment of Healthcare Providers and Systems, and that's a standard measurement out there that's measuring the patient's perception of care. VBP is one that's not heard as often. It's called, it stands for value-based purchasing. And it is a measure that is used, or number of measures that are used to determine the overall quality in the clinical measures. The intent behind value-based purchasing is to shift from paying hospitals and doctors based on the quantity of care they provide and start paying them for how good the care is. It's a great strategy, but what does that have to do with us? Why do we have to pay attention to HCAHPS scores? Well, the reason our hospitals have to pay attention to it is financial. Effective October 1 of 2012, those HCAHPS scores were translated into reimbursement changes. A portion of the hospital's Medicare reimbursements were at risk starting in 2013 at 1%. It's up at 1.5% for 2014, and it grows to potentially 2% of revenue lost by 2017 if these healthcare organizations are not meeting the targets on their HCAHPS scores. So those percents seem very small. But if I look at just my organization, 6 hospitals at the time I did this calculation, that 2% equated to $250 million at risk if we don't hit our HCAHPS targets. And that is lost revenue with no decrease in the cost of the patient care. So we still incur the cost if we take care of those patients, regardless of the outcomes and regardless of the HCAHPS scores. There are other performance factors that affect reimbursement now as well. Readmission within 30 days of discharge, hospital-acquired infections, and hospital errors. So again, what does this have to do with benchmarking? It helps set the stage for those of us in the HCM profession to understand how important the impact we have can be to the overall health of our organization. So what happens if the facility is responsible for an error and the patient actually goes to another organization to continue their care? The facility that was responsible for the error has to pay for the cost of that care. So that means that my healthcare organization could be paying our competition to take care of a patient that used to be our patient. That's a bit of an ugly scenario if you think about it. And that's part of what led to this whole concept of accountable care organization. So what is an accountable care organization? It's supposed to be a group of doctors, hospitals, and healthcare providers that work together voluntarily to give coordinated, high-quality care to Medicare patients. They are supposed to ensure that the patients, especially the chronically ill, get the right care at the right time. The goals around that are to avoid unnecessary duplication of services and preventing errors. If the accountable care organization is successful in reducing errors, improving the quality of care, they all share in the savings or the increased reimbursements from Medicare. So how does all of this affect what we do every day? It means we have to be able to demonstrate our value in helping our organizations meet their objectives. We're responsible for quality, cost-effectiveness, and error-free service. Is there anything that we do that we should measure and track to use for the purpose of contributing to these outcomes? This is where the self-assessment comes in. We have to look at ourselves and identify things that we do on a daily basis that could be measured in a way that would support our organizational objectives in reducing costs and providing high quality of service without errors. Some of the things that we do on a daily basis that are usually pretty easy to measure and then marry to our benchmarking report. We have scheduled service, and there are some things now that are mandated that we have to track. We also have unscheduled service. Some of the things that are worth tracking in terms of unscheduled service, actions that we do to manage the technology, whether it's pre-purchase evaluations, whether it's an assessment of the total cost of ownership, whether it's determining when it's appropriate to retire devices. All of those are technology management actions. Equipment uptime is important. The time to respond to service calls is important for customer satisfaction, and that in turn can have an impact on patient satisfaction. Part of the HCAHPS measures are that the nurses and physicians are measured by the patients as to how quickly they respond. If a nurse is running around the unit trying to find equipment that works, and they call and we don't answer, they're going to be delayed in getting back to take care of that patient. So our response to the nursing staff could indirectly or directly affect the hospital scores on the responsiveness of the staff. Time to complete repair, and do we include our documentation in that or not? There are some levels of ambiguity around all of these things that we're measuring. We'll talk more about that in a little bit. The number of repair requests, the number of devices in our active inventory, those are pretty easy to track. Equipment-related incidents, we don't like those, but we need to track those for a variety of reasons. One, so we can investigate and try and help prevent them from happening again. And that goes back to that error-free healthcare that we're hoping to deliver. And the number of equipment incidents as a portion of the number of active inventory is a ratio that is pretty easily tracked between organizations. And so depending on the size of your organization, a larger organization would be expected to have more equipment incidents than a smaller one. So we put that in the terms of ratios. And the same for the repair request for active inventory. The ratios are usually easier to track and compare for benchmarking purposes. And the events of user training, there's value in that. It demonstrates to administration, for example, that you're doing more than just staying in the basement fixing equipment. If you're out involved with the user training, then you're helping to contribute positively to that quest for an error-free environment. So those are some of the external factors and internal parameters that we want to look at. There are also internal values that we can provide, but only if we're measuring ourselves and verifying that we are on track with our goals there. And so we measure and track these internally to demonstrate that we're in alignment with the organizational goals, and we compare against ourselves for year-to-year performance. If we are performing consistently from year to year, that's good, but hopefully as we start to measure these things, we'll identify areas where we can improve, going back to that improvement curve from the earlier slides. And if you can move up that curve even a little bit every year, you're going to eventually get to that best practice point. And all of these things that we're measuring are potential justification for operational growth, like I mentioned with our cath lab position. We can use these metrics to identify where we need better tools or different tools, where we may need more test equipment to improve response time or completion time on PMs, where we may need training so that we're not dependent on the vendors as much to get that equipment up and running. And adding technicians always seems to be something that we want to do. It's good that we look at ourselves and assess where we are performing from one year to the next, but we must also look at what's happening outside our organizations. And that's where we may find opportunities to learn from others. We want to seek to understand the best practice. What are they doing and how are they doing it, and is it something that we can do to improve our own outcomes? And there are a lot of times when I'm doing these presentations that I hear comments about how an organization is unique. The way we do things is different than the hospital across town. We can't compare ourselves to the hospital across town because we do it this way. We take care of all of this equipment. They only take care of that small portion of equipment. And that's okay. The whole point of benchmarking is to find ways that you can compare. So you look for similarities instead of differences. And that may mean that we have to change our own measurement or add to some of our measurement parameters to be useful to align for comparison. And so especially if you're using AAMI or ECRI's benchmarking, they have those set parameters that they want you to report so that they can use it for comparison. The way I like to look at the data that we should collect is very straightforward and simple. It needs to be meaningful and it needs to be readily available. If we're wasting time trying to get the data, that's less time that we can use to change our practices and change our processes once we have data in hand. And so we want to focus on information versus just tracking numbers. If it is a number that has no relevance to anyone else or even to our own performance from year to year, like I mentioned earlier with just the number of repairs, if we don't put that in a ratio of some kind to make it a piece of information instead of just a number, then it's not providing the return that we need on our invested time and energy. And as I said, there's a lot of debate over the definitions, and we have a lot of excuses to avoid standardization. But if we focus on what's the same, then we can refine that and expand that and continue to get better. Hopefully you all got a handout that shows just years of collected information. I'm not going to spend time on that today. If you didn't get the handout, John explained, I believe, at the beginning where you can go to get that, or you're welcome to contact me and I can send it to you as well. I want to pause for just a minute here, find out if anyone has any questions or comments so far. All right, I'm not seeing anything pop up.
Karen, I've got a question here from Mike.
Okay.
Mike says, we are busy trying to just keep up with the equipment-related work. How do you suggest we find time to collect all this data?
Oh, that is painful, no question. And it's going to be an added work activity at first. But what I've found is that as I started collecting this data, it led me to answers that I could use to change processes to reduce the workload for my staff. We reduced the number of PMs on several devices. That put more hours back in our technicians' regular day so that they could focus on things that added more value to our customers, like the user training that helps provide a more error-free, or hopefully a more error-free environment. And then also, if we can reduce costs, that sometimes is justification for an added position. So thank you for that question. And John, feel free to interrupt if any others come through. I will go ahead at this point and talk about the process of benchmarking. If you think back to that arrow where we talked about putting the team together and collecting the data and then analyzing the data, when you're at that point of analyzing the data, it's important to understand sources of variation. What I started doing, and again, not that my process is perfect or that it will work for everyone, but it's just an attempt to share some things that may be useful for you. I started tracking, in addition to all of those lines on the spreadsheets from year to year to year, I started tracking significant events that happened within our department each year. Something like a hybrid OR opening at one of our facilities. So that's not only a change in our inventory of equipment, it's also a change in workflow for the users, and it's a whole different set, potentially, of patients coming in. And going back to the reasons that we need to have an error-free environment, this disruptive technology, even though it's pretty common now, originally it was a bit of a disruption to our workflow, and that increased a number of questions that we got, not just repairs, but questions. It increased our involvement in user training, and that all required more labor hours than just a standard repair would have required. Our MedTech Speedway, that's an off-site location. There's travel required for any work that we do out at that facility. So there again, that takes away from our available hours on site in any one organization. PO issued for TrueBeam and CT Sim. Okay, so that tells us we have some equipment planning time that was necessary during that year. And I won't read through all of these, but hopefully you get the point of why there's validity in tracking significant events for your department. Anything that may impact your standard measurement numbers are worth tracking, just so that you can go back and identify if there was a blip and you don't look like you improved this year in comparison to what you had done the prior year. Was there some external cause for that that had nothing to do with the process change that you put in place? So that's where that continual cycle of validating what you do is important. So once we collect all of this data, you've got a spreadsheet in front of you, hopefully. It doesn't look very pretty. If I tried to hand that spreadsheet to one of my administrators, they would want to know what the heck they were supposed to do with it. So in order to get the attention of our administrators, we need to collect the data in a way that works for us, but we have to present it in a way that works for them. That means we need to make it look pretty. It needs to be easily understood by those outside of the profession. And hopefully it can show some clear impact to the organizational goals. If we can share that information with the right audiences, it will help them show their administrators or their bosses or their board of directors or whoever they report to the things that are happening within their organization that are contributing to positive patient outcomes, improved HCAHPS scores, and therefore improved revenue or improved bottom line at least. So we have to find how to share our data with the right audience in the right manner. And it's important that as we're talking about who that right audience is, that we also recognize the importance of sharing it within our own team. It takes focused effort to change outcomes. So I can sit here and come up with all kinds of ideas about what should change within my department, but if I don't get that message to my team, nothing changes. So looking at some of the ways that I have presented information other than just in that big cumbersome spreadsheet. These next few slides are all excerpts of different presentations that I've done, not necessarily in person, but pieces of information that I have either handed off to clinical managers or to my vice president or even sent to hospital administrators. So we'll take a look at some of these metrics, and I'll talk about some of the highlights within each one. And that is something that's important to understand as you're putting these presentations together, as you're collecting your data and translating it into a different format that's more easily understood by others. It's important for you to understand the data behind whatever goes into that presentation, because there will be questions. If we look at our service delivery in terms of adding value to patient safety, you can see from 2009 to 2012, we had a number of safety assessments completed each year. And that's just a number. But what our safety assessments are events where something fell through the cracks that we didn't catch when it should have been caught, and the environment of care tour rounds found it and got that information to us so we could go correct it. So you can see in 2009, we were at a pretty low number. In 2010, it jumped significantly. Why? Well, again, going back to those significant events, in 2010, we brought on an additional facility, and that wasn't just for my department. That was for the whole organization. And so there were a lot of things, processes, and unique little nuances at that facility that were different than they were across the rest of the organization. So it took us a while to get those sort of under control and back into our normal routine. As we look at the fact that we had an increased number of safety assessments, our actual number of equipment-related incidents still continued to stay relatively low. And that's important because that meant that even though we had this blip in our safety assessments, the end result to the patient, which would have been equipment-related incidents, was still maintained. So that safety net, our environment of care safety rounds, was working. And you can also see that our number of active devices continued to go up as this was happening. And if you look from 2009 to 2010, our number of active devices actually decreased that year that we brought on that other facility, but that's because at that same time we had done a huge initiative to retire a bunch of devices that were just sitting in storage in one of our other hospitals. So that's where it helps if you understand your numbers, because you would get questions. I just made a statement that we brought on another organization. Well, then how did our number of active devices go down instead of going up? And that was the reason. It was because we made a consistent effort to retire devices that really weren't being used. They were just sitting in storage. And if you look in terms of added value, the fact that we were involved in equipment-related incidents and reporting our findings and are involved in the root cause analysis with those led us to be invited to participate in additional root cause analysis investigations as well. And so that is where we have now gone back and added more value to the organization. And the fact that we're tracking that, again, helps demonstrate how we are aligned with committing to support that user environment and the error-free care for our patients. From a regulatory perspective, we all know that we're supposed to hit 100% of our life support inspections, and some target of non-life support inspections. That means that the surveyors won't find 3 of those when they're on site for a visit if you're a Joint Commission accredited organization. So we've tracked our performance there, and we're doing okay.
Hey, Karen, I got another quick question if you don't mind.
Sure.
This is from Steve, and Steve says, why collect all of this information if no one is going to listen to us anyhow? Great question, Steve.
I don't know why people think they don't listen. Yeah. So again, this goes back to we don't have the recognition and respect that we believe we should have, right? I totally understand that. It's been my experience, though, that if we have this kind of information to share and we can present it in a way that is clear and easily understood by people outside of our profession, it will make them want to hear what we have to say. And that goes way back to when I was just starting in this profession, and I had the privilege of sitting in on a session from Mr. Manny Roman, and I piped up and made a comment about they don't listen to us anyhow, and he promptly put me in my place and informed me that it was my job to make them want to hear what I have to say. And so that really, I believe, was what started me on this path of figuring out that benchmarking was worthwhile. So again,
along those same lines, just had another quick question. How do I get something in front of our hospital administrators if I never get invited to any of their meetings?
Oh, that one will be different for different organizations. One of the things that worked for me is to take advantage of HCM Week. It's coming up next week, right? So use that as an excuse to send some documented success story to your administrators or to your department managers, something that you're proud of. Find a way to highlight that and either send it as an email or hang it up on a bulletin board if you have bulletin boards in your hospitals that talk about, success stories and improvements, or feed it through a manager that you support. If you have a department that you are pretty much the primary one responsible for it, get information that may be useful for that manager to make them look good to their boss and feed that information. So none of it's guaranteed to get to the administrators, but the more of these paths you can try and feed information through, the more likely it is that you'll get it to an administrator at some point. All right, any other questions at the moment? Okay, thank you. We will move on. Quality. In terms of the service delivery, how do we measure the quality of what we do? There are a lot of ways that people have come up with to measure that. I typically look at it right now in terms of my repair requests per active device and my average service events per active device. And what I track is my active devices on a PA schedule, and the number of repair requests on those scheduled devices. And in terms of doing the ratios, what this shows me is that as I have taken active devices off of the PA schedule, my repair requests overall are not going up. And that's the reason for doing the repair request per active device instead of just the repair request per scheduled device for my ratio. And then I look at my total number of service events, and I also track my service events per active device. Again, it's a ratio, and I can see that as we have continued to add devices and continued to take devices off of the PA schedule, our ratios are still moving in the right direction. We're improving in our efficiency there. Medical equipment cost statistics. This is a big one for a lot of organizations. If they're not familiar with their department, they may not understand what service cost as a percent of acquisition value is. And so if they don't know what the targets in that area are or what's good and what's bad, it may be important to use colors to help indicate green is good, yellow is not so good, red would be really bad. So don't hesitate to add some color into your information as you're presenting it to people who may not be familiar with what we're doing. And then another one that I've used just for internal department tracking is looking at our average cost per productive hour, looking at our productive hours per active device, our number of active devices per paid FTE, just to make sure that we're staying on track there, that if we've added positions, that we can still substantiate that we're keeping those people busy. In this slide, you'll see that I added the little purple comment down at the bottom that we have more devices, we're spending less time, fewer repairs, no increase in our number of incidents, and our time to complete our work improved. So just adding little comments along with the colors help get that key information to people in a way that maybe they will start to understand more about what we do. Financial measurements, those are always important because if we're reporting to our administrators, we all know that cost pressures are a big factor. We want to say that we're all here to focus on patient care, but we have to do it in a way that's cost effective. So if we are not delivering things in terms of what our financial expectations are, we're not going to find success and we're not going to find that recognition and appreciation that we deserve. And so this was a clip out of an actual year-end report that went to our President's Council. So all of our presidents saw this information. It was a little bit scary for them to actually be seeing this. And if you look at that far right-hand column, you'll see that there are some numbers in parentheses. There are some negative percentages. And this goes back to the fact that if you're presenting information and there are numbers and colors, it will help them identify that a low number isn't always bad or a high number isn't always good. It just helps to explain that in terms of your audience's perspective. Our total service cost continued to go up. Why is that? Well, if we look at our acquisition cost of our equipment, you can see that we were responsible for more and more equipment, so it would only make sense that our total service cost went up. And for those of you who are very analytical and who may be getting this PowerPoint presentation and going through it, I want to point out that the service cost ratio on this slide is different than our service cost ratio on one of the other slides. And the reason is because the data in this slide included our department revenue. So money that we brought in by doing service outside of our hospital was put into this before our total service cost was calculated. And that's the reason that these cost ratios are better than the cost ratios on the other slide. So in this case, green is good, Lower numbers are better, but we did include revenue to offset costs on this one. Sometimes numbers are really hard to find your way through, and charts and graphs are often more effective at sending an instant message. So if you look at this slide, you see that purple is our acquisition cost, and red with the little yellow inside it is our service cost. Just at a glance, it looks like our acquisition cost has gone up significantly, and our service costs have stayed relatively flat. That's a good thing. We like to see that kind of representation visually. Sorry, I've got a comment here. Yes, service cost ratio, cost of service ratio. Thank you, Pat Lynch. There are different terms that are used out there. And I think, Pat, you'll see a slide here in a little bit that will maybe put that in more perspective as well. So thank you for that comment. And another chart, graph combination that I like to use is showing what our mix of service cost is. As you can see, over time, our percent or our portion of dollars spent on service contracts has incrementally increased in comparison to our portion of dollars spent on time and materials and our in-house costs. There are a few reasons for that. Some is the additional technology, newer technology, that there aren't alternative service providers, alternative part sources for out there yet. Some of it is very proprietary information on the newer technology, like, let's see, the navigation systems and the robotic surgical systems that they won't train us on. So, of course, our percent of contract cost goes up, but we know why. And we can demonstrate that to our administrators, hopefully, through some kind of chart like this. Service cost ratio. I call it service cost ratio. I think it's more commonly referred to as cost of service ratio, COSR. But either way, it's the same number. It's in-house and independent service organizations are typically 4 to 8% of the total acquisition value. And the way I calculate it, not sure that everybody calculates it the same. Again, there are some differences out there, but if we focus on what we have in common and benchmark against that, we're going to get closer to doing things the same way.
Okay, Karen, we've got a couple of really good questions came in. I know these are fantastic to kind of broaden the presentation and give everybody a good idea of what's going on out there. The first question is, how did you collect your acquisition cost, and do you trust it?
Great question. The way we collected our acquisition cost was very tedious and very painful. I have a part-time employee who has access to our financial system, our McKesson ordering system, and that individual actually went through every one of our assets in our database, went back, found the original purchase order, and found the price that we paid for that item. So ours is an actual acquisition cost. We have that, last I looked, we have that actual number for about 85% of our inventory. And that other 15% are pretty much the low-end devices that we do an average cost on based on what it costs to get a new one today. So that's how we got it. And do I trust it? Absolutely I do for our facility, because it was off of our actual purchase orders. Great question. It took a lot of time, and it took a very focused effort. Not every organization is going to have that privilege, and I know that there are some benchmarking programs out there that offer some ballpark numbers for what typical costs are for different assets. All right, any other questions there, John?
They're pouring in, and I think we'll save some for afterwards. But another quick one was, do you use list price for acquisition cost or purchase cost? List cost would be better to benchmark with other organizations.
And that goes back to some of the differences. I didn't have access to list cost. I had access to our actual cost. So that's what I used. And I know that there are a number of organizations that use that list cost, but when you stop and think about it, nobody really pays list price. So, you know, it's 6 of one, half a dozen of another. In the total end picture, it's going to have a little bit of impact one way or another. And that's where if we go back to looking at keeping our own measurements the same from year to year, we can measure our progress against ourselves last year. And at some point, if we start to measure to an external group or another organization that's very similar to us, then we can maybe measure it both ways. Maybe measure it the way we measure it and measure it the way they measure it, just to use for comparison purposes. So there are still variations out there, and I don't claim to have the solutions to that. All I can say is if I'm measuring against myself the same way that I measured it last year, then I'm confident that my results are appropriate. Whether it's better or worse, my results are accurate.
Okay, Karen, do you want to continue with your presentation to make sure we get it all in, or would you like me to keep firing off some of these great questions?
You know what? Let me move forward just a little farther, and then there are a few slides at the very end that really are not as relevant probably as the questions. So let me move forward just a little bit, and then I'll stop it, John, and we'll turn it back over to questions. So again, the typical in-house and independent service costs range 4 to 8% of the total acquisition value if you are doing a complete service, meaning general biomed, laboratory, and imaging. Recognizing that the laboratory for those high-end analyzers and the imaging equipment for those expensive tubes and detectors are going to have a much higher percent of their cost ratio is going to be a much higher percent of the acquisition value than a patient monitor that never breaks and that you can fix with a $5 pot. So those are things to keep in mind as you're benchmarking. Compare your organization, the scope of service, to an organization that has a similar scope of service. So if you're just doing the biomed work in your facility, don't compare yourselves to an organization, for example, that just does laboratory service. It's not an apples-to-apples comparison. And for my organization, the things that I include in the numerator for my cost of service ratio, I use my department budget, so that gets my training, my travel, my tools, my vehicle expenses, everything that's in my department budget. It gets that thrown in there. And I look at the parts, at the vendor labor, and at service contracts. I add all of those together, and then I also look at this category called miscellaneous repairs, where a number of things that may be in my inventory are actually sort of fixed by other entities. And that's where that miscellaneous repairs is, again, specific to our organization, that tracks some of those costs. And those range typically less than 1% of my total budget, my department's budget every year. So it's not a significant factor, but I wanted to clarify that, you know, mine's a little bit different than other people. And that whole numerator then is divided by my actual acquisition value, not list price, not typical target price. It is my actual acquisition value. And if you look at vendor contracts, the ones that I've seen come in lately, especially for the new imaging systems, are closer to this 14 to 18%. And some of them, like for our linear accelerators, are even a higher percent than that. One other measurement that our administrators are used to seeing is in terms of cost per adjusted patient day. That really doesn't have much value for us, no question, because equipment breaks, whether it's in use heavily or whether it's not, or whether we have a high census or whether we have a low census, stuff can still get dropped, it can get knocked over, it can not pass its startup test of a morning that it does just in case it may have patients coming in. So I'm not convinced that service cost per adjusted patient day is really a valid metric, but it's an indicator in terms of patient days that our administrators are used to seeing. So if I want to speak their language, I need to put part of what I do in terms that are familiar to them if there's any possibility of it making sense. So one more slide, John, and then I'll turn it over to you. It's true that benchmarking today, not everyone measures everything the same way, and we're probably not ready to do side-by-side comparisons. But if we don't start using the information that is available, we won't figure out what's useful, and we won't find out how we can compare and how we can be consistent with our definitions and our applications of this. So I believe that it's important for us to measure what we can right now while we have access to any information and then refine it as we go. So John, I'll turn it back over to you if there are questions. Hello?
Karen, is that it? You ready for a question?
Yep.
All right. How about your equipment per technician seems very low compared to the industry. That's from our good friend Doug.
My number of devices per technician?
It just says your equipment per technician seems very low compared to the industry.
Okay, and I'm not questioning that it is low, and I have to go back and find my slide and identify if that was my number of devices that are scheduled or my total active inventory per technician. Either way, we have, let's see where we're at now. We have 7 hospitals, and we're supporting all of the imaging equipment in those hospitals as well. And I know that our number of imaging devices per imaging service specialist is much lower than our number of general medical equipment per our biomed service person. And so if I am not at that typical 1,000 to 1,200 devices per employee, then it's because I believe we have demonstrated that we are better at providing value by focusing on those high-end devices and getting the skills and the resources in here that we need to support those, instead of just going around doing the electrical safety checks on all of the random pieces of equipment. And so if they decide to cut more positions from me at some point because my numbers are lower than the average, well, that's a chance I'm willing to take. So I do appreciate you pointing that out. And again, just going back, I found it now, my average number of active devices per paid FTE. So yeah, I was at 743 for 2012. So that is lower than what a lot of places are. I do understand that. But again, it's because we've justified the time to focus on the higher end technology and drive the cost out of the organization instead of focusing more on the lower end. So thank you. Other questions?
Yep, from Brian, are you using the value of the inventory that you generate revenue off of for your as part of the total?
Good question. We are not. When I look at my service cost as a percent of acquisition value, I separate out any assets that are at a billable account, and I also separate out the cost of service for that billable account when I do my internal department measures. On the one slide that I indicated that the revenue was in there to offset that, in that slide, that inventory for those billable sites was possibly included. I'm not sure on that one. But I know our labor hours were included because then we claimed the revenue. So that one's, again, a little bit, I'm not sure. I didn't produce that one. I got it from my vice president that he got from my data and his data combined. So I can't walk my own talk there. I can't justify and validate every line in that graph. Thank you.
Okay, I got one from Mark. Is yearly integration cost included in your device lifecycle cost, and if not, why?
Integration cost is a difficult one to measure, so I will answer that with this. If the integration cost is labor from my department or labor that comes from my department or expenses that are paid for out of this medical equipment expense account that we have within our organization, then yes, integration expenses are included. If it is an expense that is part of the IT department, because we're still separate currently, if that expense is part of the IT department, whether it's their labor or whether it's a contracted service that is paid for separately, then those expenses are not in my ratios.
Okay, I think that about answers all the questions. Karen, did you want to have anything else to say before we wrap up here?
I will go on to talk just a little bit about self-assessment of the future. We know it's going to change, so find a way to be productive. What I'm looking at doing that, you know, isn't in full force yet, but it's looking at not just incorporating our true metrics in terms of the number of work orders and the number of repairs and all of that, but the quality of the work. It's not so important to fix the equipment as it is to fix the customer, and you have to do them both together. And so I'm looking for a way to incorporate behavior standards into some of my benchmarking, and I haven't found a way to do that yet. But in the slides you'll see that there are some behaviors out there that I want to start finding a way to benchmark against other technicians. I believe that it's important that we all demonstrate that we're willing to be accountable for our role, that we take the initiative to demonstrate our capabilities, because that's the only way we're going to earn the respect that we want. We have to set the bar for ourselves before someone else sets it for us. And I love this quote from Quint Studer: "It's never underestimate the difference you can make." And I apply that to regardless of your paid role, regardless of your position, regardless of what you do on a daily basis, you can make a difference. Don't ever underestimate yourself. So thank you very much, and thanks again to Heritage Global Partners for sponsoring us today.
That's great. I'm sorry, can't clock out yet. I got one more question just came in.
Okay.
Can you explain how you help your organization with end-of-life purchases?
Okay, so I'm not sure that I understand the question, so I'll answer it a couple of ways. End-of-life purchases, if we have equipment that needs to be replaced because, first of all, because the vendor says it's end of life, we do our own evaluation on that. And if we can still continue to get parts, and if we have the expertise to support that equipment in-house, we will recommend that they continue to leave that in service as long as it still meets the clinical needs. So just because we get a letter from a vendor that says something is end of life, we don't consider it end of life. We evaluate it for ourselves. So that's sort of one angle to that question. The other way I could interpret that question is, what do we do to support our customers if something really is end of life? We look at what our service trends have been. If we start to see more repairs or more costly repairs as the equipment gets older, then even if it still meets the clinical needs, and even if the vendor isn't saying it's end of life, but if we have, for example, a newer device that is not requiring as much maintenance, that would sort of indicate, hey, this one has, this other one that we're having all the problems with has the opportunity to be replaced by this device, and look at the typical difference it's going to make in your operating budget. Those are some of the kinds of pieces of information that we share with the departments to help them make good decisions about what to replace. So hopefully that answered the question.
Okay, great. As Karen said, we'd like to thank today's sponsor, Heritage Global Partners. They have a great two-day global online auction coming up May 27th and 28th. Please go to hgpauction.com for more information. Also want to remind everyone that this participation makes you eligible for 1.5 CE credits, and a survey about today's presentation will appear on your screen immediately following the seminar. Once the survey is complete, we will email your certificate with CE credits within 2 weeks. All of you should have received a copy of this presentation via email right before the webinar began. However, you will be able to go to imtechnation.com/webinars to download the entire presentation. So again, special thanks to Karen, one of the pillars of our industry. We would not be where we are without her. She speaks at several shows. We're lucky enough to have her at our MD Expo, so thank you again, Karen. Next webinar is going to be the one and only Manny Roman. That's going to be on May 28th, discussing the 7 triggers to yes. And as another reminder, TechNation is be holding our VIP Reader Appreciation Party at the Amy Show on Sunday night, immediately following the show in the conference hall at 7 p.m. Go to onetechnation.com to RSVP, and it's complimentary. It should be great networking, and we look forward to seeing you all then. So again, thank you all for participation. Have a great rest of the day.